Good morning. My name is Jake Mantuffel. I'm from Henry Ford Hospital in Detroit, and I'm an emergency medicine doc, and I'm also an addiction medicine doc here. And I'm joined by my co-host here. I'll go let Dr. Rademacher introduce himself.
Thanks, Jake. I'm Nick Rademacher. I'm an emergency physician in Grand Rapids. I've been working with the Michigan Opioid Partnership for about 4 years, and I also am certified in addiction medicine as well.
Yep, and so this is actually the sixth of six little webinars or lectures we're doing on a broad scope of medications for opioid use disorder, and this is the last and possibly most critical portion of this series, which is focused on the warm handoff and community resources for patients when they are leaving the emergency department. So without further ado, we'll get ahead and get started. And we are both technical assistants for the Community Foundation for Southeast Michigan. However, we do not receive any financial benefit from the prescription of medications or for the treatment of opioid use disorders. So things that we are going to cover today, the first thing is define what a warm handoff is, since that is like in our title slide, and understand the data and literature that supports the role of warm handoffs in patient retention and treatment, improved mortality, and decreased likelihood of overdose. Also, to understand how mechanisms for identifying community resources for patient follow-up are identified, and to understand the opportunities for quality improvement associated with your outpatient referrals. So this is a recurrent slide here, but just to underscore the emphasis for why we're doing this work and why we're emphasizing, although I think the national headlines are showing a slight decrease in overall opioid fatal and non-fatal overdoses, which is good news. However, in our most, I think, susceptible communities or those most at risk, there continues to be an increase, particularly in our Black patients, Detroit, Flint, and the mortality increases or decreases are not being seen. So still lots of opportunities, specifically within the health equity lens to improve outcomes for patients. But this rise was really fueled by the synthetic opioids, fentanyl in particular, getting into the drug supply and causing these steep increases in opioid deaths over the years. And COVID made things worse. And as I mentioned, I think the most recent data that I have not seen actually in graphic form yet sounds like we're starting to level off overall on average, but still lots of work to do and continue that momentum down. Opioid use disorder is terminology we like to use because the words matter. There is a ton of stigma in this patient population, and this is my recurrent soapbox slide. I like to just take a minute to understand, because if we can recognize that the stigma exists, that really is the first step into recovery and treatment of patients. So we as providers stigmatize these patients, our hospital staff and nurses, techs, they stigmatize these patients, and the patients stigmatize themselves. And so acknowledging that's the first step and trying to overcome that is a huge part of recovery. And just understanding that addiction is a disease, not unlike diabetes. We have the medications to treat diabetes. When patients come to the ER with elevated blood sugars, we don't say, oh, look at that person, they're really messing up their life. We just treat them. We give them the medication they need, and we make sure that they are set up to go on as an outpatient. And this addiction should really be the same, especially with opioid use disorder. We have the medications to treat that disease. We have the resources in many places to connect them to care. And sometimes just knowing those resources is a first step for providers, and to make sure that the patient has what they need when they go, and have that warm handoff that we'll kind of focus on here today. So can't emphasize that enough, that we really need to acknowledge the stigma and try to get past it. And we use the terminology MOUD a lot. That is medications for opioid use disorder, also known as MAT, M-A-T, medication-assisted treatment. MOUD is kind of the new terminology, just to emphasize that in a lot of cases that the medication itself is the treatment. And I also wanted to mention we do have a few attendees here today. I think Nick or Naomi will monitor the chat. And if you guys have any questions, we were always happy to stop and answer. I'd like to make this as clear as possible. And any audience participation is typically better because other people probably have the same questions you do. So please stop us if you have anything. But otherwise, we'll move on to the course content here. And as mentioned, we'll cover warm handoffs, the definitions, some research associated, and the composition of the team that you might have providing those warm handoffs. And secondly, we're going to talk about the community landscape. And it's another slide that we've seen in the past. We'll dive into a little bit more and understand how you can access uh, treatment options for patients, even those that are underinsured or have no insurance, and to kind of mull the options that you might have for referral. So definitions, what is a warm handoff? A warm handoff versus a passive referral. Warm handoffs are classically referred to as the process of transferring the healthcare from one patient, from one healthcare professional to another directly in front of a patient. And in the ED, those handoffs are typically referring to connecting a patient to care beyond the ED. A passive referral involves giving the patient clinic information or resources, and it's really on them to call and arrange for follow-up after their ED care. A warm handoff involves a member of the ED team arranging for the next steps, the appointments, and with the details of the appointment typically known prior to ED discharge. So there's some active work in making sure that handoff occurs. So a warm handoff, transfer of care before the patient leaves the ED. A passive handoff is giving the patient phone numbers to call and not really considering some of the other barriers that person might be realizing along the way. So expanding a little bit more on warm handoffs, for patients with substance use disorder, warm handoffs are really considered best practice. You can consider that a lot of these patients have, potential homelessness to deal with, financial problems, lack of transportation. And so the warm handoff, it usually takes those things into consideration. And it typically gives the patient an appointment and a place to go and a time, along with likely transportation. So, and then the other social determinants that might be at play as well are considered, say a person was in the ED and they have serious dental issues, and that would be a consideration about where you're referring them to. And there's a community organization that actually has an affiliated dental clinic, for example. In some cases, your patient may just be able to manage this on their own, but in most cases with substance use disorder, it's wreaked such havoc on their life that they need extra help in order to make sure that they're able to follow up. So who does these warm handoffs? Typically either a peer recovery coach or social work, or a lot of times there are nursing navigators. Those are some of the models that I've seen, and they are essential to making sure these warm handoffs occur. They do the legwork and make sure that the patient's going to the right place for them.
Jake, I wanted to add a little bit more to that
Yes.
slide. I think in medicine, we're all familiar with the Swiss cheese model of medical errors, right? And that a lot of different variables kind of have to go wrong for someone to be injured, right? If you're going to give someone the wrong medication, first you have to order the wrong medication, and then the nurse doesn't notice, and then they don't follow protocol, and maybe don't scan the medication. Right? Many things have to go wrong in the Swiss cheese model for the patient to actually get the wrong medication. It's actually the opposite for opioid use disorder, and it's a Swiss cheese model for it to go right, because there are so many episodes of stigma and barrier for them that it's really amazing when it actually goes well, and that's why this extra care for warm handoffs is so important. Again, we talked about stigma, and so all it takes is one person to say something derogatory to them, and they're just going to leave, right? Or you don't get the medication fast enough, and they're not going to want to do it. Um, Say their emergency department visit goes great. I've had it where I did the prescription, did the induction, got a warm handoff, but then the insurance company has them assigned to a specific provider that can, because they have doctor shopped in the past, only their primary doctor can prescribe opioids for them. Buprenorphine is considered an opioid, and so when I prescribe Suboxone, they can't fill it. So there's an insurance barrier. Or they get to their pharmacy. Maybe they still live in a small town. There's only one pharmacy, two pharmacies. They get there and the pharmacy doesn't have it. And so these are the type of things that have happened to a variety of patients for me, which is why it's so important to use extra care to make sure they're getting where they need, because there's just all these things that come up that make it hard for them to complete the course of treatment that we're trying to get them to do.
Yeah, that's a great point, Nick. And typically, we use the peer recovery coach model at Henry Ford, and they all have cards, and they tell the patients, "Hey, call me," and a lot they'll even hand out their cards to patients that don't want services on that particular ED visit, just to kind of plant the seed and let them know. And patients will call, and when they reach some of those insurance barriers or medication access issues, they do call, and we work with them. They will call me and say, "Hey, what can we do for this guy?" And unfortunately, some of the cases just say, "We'll have them come back. We'll make sure we get them. They don't have to wait and triage. We'll have somebody go out and make sure they get their pupe right away, just so we can buy them another 12 hours to figure out what the next step is." Yeah, that's a great point. That it's the opposite of the Swiss cheese, where you need everything to line up for it to go right, just because everything that they face. Some of the literature that supports the warm handoff goes back to the original paper that's kind of the landmark paper in opioid use disorder in its initiation in the emergency department. And this is Dr. D'Onofrio's paper. This really focused on the fact that if you give patients their first dose of pupe in the ED along with the warm handoff, they have about an 80% chance of retention in the outpatient. Whereas if you just give somebody resources, the passive referral, no buprenorphine, you're going to be at around 20 to 30% success rate of being linked to care at 30 days. And then somewhere in the middle, if you give them a warm handoff but no medication, you're in the 40 percentile, 40% range of getting linked to care. So it's kind of a landmark paper that when we get the medication on board and make sure that the patients are set up in the right spot, actually there's a high probability that they will stay engaged in care. And the specific outcome in this was 30 days, 30-day retention and treatment. So I'm going to hand off to Nick for a couple slides here.
Yeah, thanks. So there's actually been a couple. So again, I've been doing this for 4 years, and my first experience with treatment for opioid use disorder was in Flint. I worked at Hurley Medical Center. We actually were able to start because we got some peer recovery coaches through the New Paths program in Genesee County. They're amazing, and that kind of kicked off our idea that we should start treatment in the emergency department. It was a couple of years after the D'Onofrio paper, but for a long time there hasn't been a lot of research showing that peer recovery coaches were beneficial. There's just been this absence of data. And so I've been saying it as an article of faith that it was just true because I saw that it worked really well, but I didn't have any citations. And then over the past year and a half or so, we've had a couple different papers that have actually shown there are benefits to using peer recovery coaches. And so here's one. This was a pre-post implementation model. So certainly there's some flaws in the study design, but I think the data is important regardless. Shows that for those so in all these different colors here, they're matched pre-post. And so the blue, the one to the right, you can see if you have a peer recovery coach program with your opioid treatment program, then your ED visits are less frequent. And then your opioid related ED visits are even less frequent. And then your hospitalizations are less frequent. And opioid related hospitalizations 1 year after are less frequent as well. And so it's better patient care. I think what we joked when we started doing this that most hospitals and healthcare systems, their objection to doing an ED-based buprenorphine program was that there would be an opioid zombie apocalypse at the hospital, that you'd start prescribing, and what would happen is you would just get this influx of people seeking buprenorphine. And it's funny in hindsight because I think we all wish it were true that people would flock to us. And the truth is that due to stigma, it still actually takes a lot of work to convince people that they should be doing it. But what we see is the most effective treatment medications plus peer recovery coaches plus warm handoffs actually reduces how often these patients come into emergency department. And so that's good care. And considering that a lot of times these patients are uninsured and they get hospitalized for soft tissue infections, endocarditis, and you might need long courses of antibiotics. It's a bit of a money saver for the hospital if you can show that you can actually reduce hospitalizations in those with opioid use disorder. Um, sorry, a little bit of background of that study as well is I think a lot of times we wonder how exactly are they doing all this. So this notes of this paper, not only do they help with breaking down stigma and creating relationships, but they help them provide services, get to appointments. They provided federal phones. They helped them apply for housing. They applied for medication insurance. 9 patients applied for food programs and then get bus tickets to the hospital. Um, they helped them with buprenorphine vouchers if they didn't have insurance. And then they also kind of pressed on the physicians a little bit, and they saw an uptick in buprenorphine prescribing and naloxone prescribing. And so the peer recovery coaches helped with almost every aspect that could go wrong in this reverse Swiss cheese model that I had referred to, where it just takes one thing to mess up the whole cascade. And then the second paper that came out this year, Jake had talked about the plateauing of opioid-related deaths, but that doesn't necessarily translate to urban centers, and that we know our Black patients have had higher rates of complications and death from opioid use over the past several years. And so this is another one where we talk about this problem, and then you kind of get into solutions and it's a little bit fuzzy. I mean, I think there's probably increased stigma with racial minorities, and I'm certain that's true. And then there's insurance issues, but I mean, it's a little bit hard to have a concrete solution to this. I think sometimes biases are deeply held. But here is actually a paper that shows that one way to increase treatment retention in patients who are Black, and that is to have a peer recovery coach. And so while all racial groups in this study showed improvement in retention, Black patients had the highest differential, and that there's a 73% improvement in retention if you have peer recovery coaches. So it seems like this is one piece of evidence that shows that if we're trying to close that gap in racial disparities, this is how we can do it.
Nick, I was going to go back to your slide just for a second here, just to
Yeah.
pile on. Although our data is not published. The experience that we've had looking at a couple years of data, it shows the very similar that we've not seen the opioid zombie apocalypse. And I think that's the concern that those folks are. If you are known to be open for business to treat patients with opioid use disorder, it's one of the stigmatized beliefs, I should say, that you're just going to have your ED get flooded with patients, that are just coming in for their daily dose of Suboxone or whatever, which is really not the case. And what we found was that we had in 60% of our patients where we initiated buprenorphine in the ED, and all of them were engaged with a peer, that in 60% of the patients we had 0 or less ED visits than they had in the previous year. And in terms of hospitalizations, we've had it was 75% either had 0 hospitalizations or less hospitalizations that they had in the previous year. So again, unpublished data, so I don't have slides for it, but we've presented it at ASAP and SAEM, just as some growing data. It's not the last round of it had about 130 patients, and it hadn't reached statistical significance yet. So that's why we opted to, not go for publication just yet, and just have to keep up our chart review. And at some point we will, as long as the trends continue, which I'm sure they will.
And then sometimes people ask, well, why is this so important to get people on medications and have them continue for a long period of time? And this just is another slide it's busy, it's retrospective, but the gist is that if you're on buprenorphine or methadone, the risk of an opioid overdose is significantly less than if you choose for inpatient detox, or just um, no therapy at all, or just counseling. And also you have decreased use of acute care, so like emergency department visits. The the treatment line is the top one. It's hard to see the colors in this, I think, but the top line for both is the MOUD with buprenorphine or methadone, and then invariably the worst outcome is inpatient detoxification and no treatment at all. So it's important to be on treatment, and this is one of the graphs that shows why.
Yep, and we'll revisit this one actually later in the slide set. So continuing on about warm handoffs, so who does them? And there really are three models that I'm aware of. That you have a peer recovery coach, which is what we use, and I think is the most common. But some places still really have really active social work departments. I think actually our Henry Ford Jackson was using their social worker work department predominantly before they got a peer in there. And I think Beaumont has a really good, or I should say Corewell, Royal Oak, Beaumont, Corewell has the STAR model, which is clinical coordinating nurses, which has been pretty effective for them. All of them have their pros and cons. With peer recovery coaches, they unfortunately, they provide great value, but they are not paid that well. And from a cost perspective, they definitely are the most cost effective. They don't require advanced degrees or even a college degree, typically. And there you have the added peer interaction benefit. So, we can always tell patients, stop using drugs or, this, that, the other. But, peer recovery coach is somebody that's in recovery, can very much connect with that patient in a different way than we can, and often are the key factors in getting a patient to be agreeable to engage in treatment. With a social worker, at Henry Ford in particular, we are understaffed with social workers. Offloading them with our peer recovery coaches has been a huge win. They are, typically arranging for long-term care or, inpatient, outpatient rehab, or many of the other social issues that your department's facing, and they cost more. They usually have to have a master's in social work in order to practice as a licensed medical social worker. So they're going to be more costly. There are definitely some benefits with a clinical coordinating nurse, particularly if they're at all affiliated with an outpatient clinic. They can give long-acting buprenorphine injections, and so there's definitely some value there, but they are typically significantly more expensive, probably exceed the cost of a social worker as well. So those programs can be grant dependent, although hopefully you can talk to your hospital administration and show the cost savings. And there should be folks that be willing to pay for this when you look at the scope of healthcare and what benefits this can bring from a cost perspective. So diving into a little bit more about the peer recovery coach, these folks, in order to be certified in the state of Michigan, are typically have a 40-hour course to complete, which describes their roles and the functions and builds their skills to enhance relationships. There's obviously probably a predisposition to doing this kind of work if they are going through the training, but learning also about co-occurring disorders and psychiatric conditions and some medications that they might be taking. Learning about the stages of change from pre-contemplation, to willing to engage in care and continue in care, relapse, etc. Some of the ethics involved in general wellness planning and having the ability to practice their skills. If you're going to hire a peer recovery coach, the typical time in recovery is somewhere between 2 and 4 years in order to be actively engaged as a coach. So these are folks that have put in some significant, life-altering changes and gained some skill sets in order to continue to do this work. And the peers can be engaging solo with patients outside the hospital, or they could be an employed model within a hospital. Their scope of practice, is typically under someone. However, they can be broad, and a lot of the benefit that they can bring when your peer recovery coach system is set up well is they can continue engagement beyond an ED visit. So checking in with a patient, making follow-up phone calls if you have the bandwidth and capacity to do that. I know in some of the more rural areas, sometimes the coaches will even drive patients to their appointments, if needed, because they just know that they are going to reach a lot of these barriers that occur with substance use disorder. So navigating the outpatient landscape, I want to take a little bit of time to actually go over this figure here on the right, which shows the regional prepaid inpatient health plans. For a lot of our patients that have Medicaid or no insurance at all, they're not going to be able to get into your cushy outpatient rehab places. They're going to have to be reliant on state-funded resources, and this is how the state pays for things. And it's broken up into regions. Obviously, the whole entire Upper Peninsula is considered Region 1. Northern Michigan is Region 2. And as the population increases, the regions get smaller in geographic size. But you have the Detroit Wayne Integrated Health Network down here. That's number 7. And these are each one of these entities contracts with a number of organizations, and they will be the entity that will be able to arrange, if say, for example, for peer recovery, if you're going to have peer recovery coaches embedded or on call for your emergency department, they are the entity that you want to talk to, get the list of places. You may or may not want to visit those places just to see what the quality of the conditions are that you're referring patients to, or maybe rely on your peer coaches to give you some feedback on what are the best places. But ultimately, peer recovery helps navigate those resources, and they are aware from talking to the patients, what places are good, what places are bad, or what places might have extra resources that they might need, like wraparound services, including mental health, dentistry, or affiliated housing, as temporary housing for patients that are homeless, but don't necessarily want to be in an inpatient treatment facility. This is also the organization that, or these organizations would also be the places that would help set you up for an inpatient treatment facility as well. Again, peer recovery coaches, as I mentioned, they are really the experts in navigating this, what I would consider a very complicated outpatient landscape. And this may be news to people or even docs, within my own facility, that this is how the resources for substance use are handled. And we really take it off the plate of our providers to try to figure this out. I feel like if we would have major issues if we just said, okay, staff doctor in the ER, make sure you set them up for outpatient, at the right place that, takes their insurance, that they have transportation for, et cetera. That is just a barrier, and it's definitely a pitfall or a stumbling block if you're trying to rely on docs who are busy doing lots of other stuff to try to figure this stuff out. If you're able to train your group to do that reliably, good on you. But I actually don't think it's reasonable. And I personally, even though I have fairly extensive knowledge of this process, I never tried myself. I rely on my peer coaches because I know they know what's best and they know the landscape. If you do have patients that have their insurance that your group takes, or you have and you can refer internally into your own system, that is ideal. There is generally a paucity of physicians that are willing to take patients with substance use disorder because they are uncomfortable treating addiction. Although I would say that that's a growing cohort, particularly in our family practice colleagues locally. They're getting more and more willing to be the go-to for us, which is great. They want internal referrals, so trying to build those pathways is a process in itself. But we are interested in doing that because that allows us to find out if they actually went to their appointments and if they're being maintained in care, and kind of tracking some of those variables to improve on the quality that we're delivering in terms of medications for opioid use disorder treatments. Anything else you wanted to add on this one, Nick?
I think you covered it.
Good. So Digging more into community resources, so there are the outpatient clinics or the inpatient rehabs. Another very good resource, at least locally for us in Detroit, is the CHAZ Clinic, which is a federally qualified health clinic. And if you have any of these locally, the nice thing about these facilities is they will take any patient regardless of insurance, and especially those with no insurance. I think most patients in Michigan, given the Medicaid expansion, actually qualify for some type of insurance, but they're unaware, and some of these clinics can help make sure that they, reapply for insurance and have a lot of the resources that a lot of the patients that have social determinant barriers are accustomed to. So FQHCs are definitely places of note. If you've got that patient that has no insurance and that maybe they don't even have an ID, I think that FQHCs deal with those kind of issues fairly frequently, and might be high on your list for referral. I just put in some of the local PIHP contracted outpatient centers that I'm aware of, and actually New Paths is in Flint, and one of our colleagues, Dr. Borgiali, is the medical director there. So that's a kind of a nice, he's an ER doc and addiction medicine doc, and is the director of New Paths. So obviously that's a strong relationship. Home of New Vision has been a good partner for the Henry Ford Jackson colleagues, and I do know quite a bit about quality behavioral health and Team Wellness in Detroit. There are multiple places, Detroit Recovery Project. Who do you have out in Grand Rapids area, Nick? Like, what's your
We have
go-to
Red
places?
Project,
Yeah.
and they, I think, started mostly as a needle exchange, HIV testing site, and then they've expanded. They have like uh, a naloxone distributing machine right outside their door. They now have a couple peers, and so they've expanded to fill in a lot of services for patients.
Yep. And in particular, in your more rural areas, mobile resources might be the go-to. So I know, for example, in Kalkaska, who's affiliated with the Munson system up north in Region 2, PIHP, there is a mobile clinic that comes, to the Kalkaska site, once a week, or, depending on the patient volume, to help deliver services. So again, the regional PIHPs will help let you know what those resources might be, and it does probably require some planning to make sure everybody's on the same page. But again, Peer Recovery, if that's your go-to resource, will let you know what's available. And I mentioned this a couple of times, but the co-located resources can be huge for patients, just because they are dealing with a lot of issues. And sometimes they might not even see their substance use as the primary issue, and the only way for you to be able to get them engaged is to let them know that you're willing to help on some of the other things too, like housing, for example, which can be tough. But there are places that have some options for patients. Outpatient clinics, ideally, like I said, if you can have them within the same hospital network, then you can get some of the QI and QA opportunities with the shared EMR and tracking patients. I mentioned family practice. I don't know if it's the same in Grand Rapids or across the state, but locally they're strong, and advocate for patients with SUD and are willing to treat patients. Addiction medicine clinics, you're probably going to be getting a subset of specialized insurances, or your Blue Cross Blue Shields, or HAP at Henry Ford. You have to have something like that in order to get into the true addiction medicine clinic. And it's not necessary. I mean, if you have somebody that has a severe opioid use disorder, a lot of times our FQHC locally can refer patients into the addiction medicine clinic and get some guidance for future care going forward. But any primary care really can treat these patients, and like I said, it's a limited cohort, but I do think it's growing. I think there is a lot of information that's going out to docs about how to treat these patients, and also creating awareness that this is in all patient populations. It's not only in the downtrodden, or the poor. That substance use disorder definitely crosses all socioeconomic classes, and that primary care docs need to know about this and need to be able to treat patients as well. And as mentioned, those insurance limitations may lead you to some of the other places that we talked about. So inpatient rehab, as I mentioned in that slide, I think we'll revisit in a minute. It's really should only be for patients that have severe opioid use disorder. unfortunately, I feel like it's the default for a lot of our homeless patients, although there is still a subset of patients that are homeless that don't want to go to an inpatient rehab facility. And the problem with inpatient rehabs is it's never quite clear to me, even though I think our peers have some more insight than I do, that not all places that do inpatient rehab even provide buprenorphine. So a lot of places still will only use abstinence or the detox method, which is really dangerous for patients, frankly. And it's a reason why some of the increased mortality occurs when patients go into an inpatient, stop using all substances, and then that decreases their tolerance. And so when they get back out, if they get the craving to use, and or the circumstances present themselves, they end up using and then putting themselves at higher risk for overdose because they're going back to probably using the same amounts that they were using prior to going in, and that probably is too much for them at this point. So, if at all possible, to clarify if you're referring to a inpatient rehab that actually provides medication for opioid use disorder, number one, it'll be way more pleasant for your patient. They're not going to have to go through that intense withdrawal that we've probably seen, when our patients present dramatically, very sick, and if you can avoid that, you probably should, and it probably is the better way to go.
I would just assume that your inpatient detox locally does not provide buprenorphine unless you clarify, because on surveys about this, it is the minority that do, unfortunately.
Yeah, and that I think that's why, if you look at the orange line here on these graphs about opioid overdose at 3 months, it's right tied with those that receive no treatment at all. So essentially, it's the inpatient rehab in terms of preventing opioid overdose at 3 months is like completely ineffective, and even worse for whatever reason with acute care use. So I think that it speaks to the idea that an inpatient detox, it's fairly useless. I mean, it's essentially housing, I guess, for many patients, and unless the patient's really adamant that this is not something, they don't want to be on an opioid. And there are other options for patients that don't want to be on opioids. There are other medications you can use, your naltrexones and things like that. So there are other options for these patients, and for I think for the reasons that you just mentioned, Nick, that's why these inpatient detox facilities are not effective. Federally qualified healthcare clinics can accept most Medicaid insurance plans. So that's one of the barriers that we have at Henry Ford. What kind of insurance they have? Well, they have, one of the 65 Medicaids, and Henry Ford takes two. So this is a big problem for us. We end up relying on our PIHP contractor organizations. One of the things that I want to do actually is to refer more of our patients to our local FQHC, which happens to be staffed by Henry Ford Family Practice physicians, and they're on our same EMR as well. So that would allow me to do some of the QI and QA that I want to do on this patient population, because it becomes exceedingly hard to find out if they go to a PIHP contracted organization. Becomes exceedingly hard to find out if they're still engaged in care or not. That's really protected information, rightly so. Even if you have a signed release that will allow you to get that information, it's still extremely hard to get. And they also take patients without insurance. The barriers that you might face there is they may just not have the staffing to see the patients, or they may be full, or there may be a delay to be seen. Fortunately, at Henry Ford affiliated Chaz Clinic here, they're going to be upstaffing actually with the capacity to treat more patients with MOUD. So we're excited about that opportunity. The local PIHP contractor resources, again, they're the best people to talk to. I think that if you are getting a peer, even from that organization, they are still going to be pretty well networked. Not all organizations are going to be able to take patients, so that some might be full, or that, you couldn't get an appointment fast enough. And so there's probably going to be several options to choose from, hopefully, and your peer, will probably know who's the best. And one of the things that we did when we were setting up our peer recovery program. I'm not sure if we actually visited the centers, but we had representatives from each of the places come in and have like a meet and greet with our peer coaches, and just to have some face-to-face recognition of who's going to be referring patients, and getting some information as to what co-located services they might have, as previously mentioned. Mobile resources, again, PHP will know, and they can come on site weekly, and they may be part of a larger hospital system for your more rural locations. So I've mentioned this a few times in the last session when we were talking about peer recovery coaches in particular, but I do think that if you are able to integrate your peer with your IT group, so they can document or they can see some of the resources that you have available, it really provides you with quality improvement opportunities, and you can get data and you can go back to your leadership or your hospital and show the impact that your program is making, because otherwise it's kind of anecdotal. Oh, we had so and so, we have so and so working here, and they help the patients, and that's great. But what we are able to do at Ford, since we employ the peer coaches, but even at other Henry Ford sites that don't employ the peer coaches, that get their peers from PIHP contracted organizations, we get them integrated with the EMR so that they can actually see who is screened positive for substance use that we ask about in triage right on the track board, and they can just go and talk to these patients without being prompted. So in my argument for this model is that you're increasing the number of touches for patients, and as we know, peers are better at motivating these patients and providing the brief intervention, and they have the time to have those conversations and get into the nitty-gritty with patients and find out what are the important issues that they have and what barriers they might have, and really actually kind of parse out the issues. When you have more time with the patients, and because they're integrated with your EMR, you're going to have more patient touches and more opportunities for success. And I think we looked at a 1-year time period, and we had over 1,200 patient touches, and 20% of those patient touches, the patient actually declined any intervention. But we counted those as successes because, number one, we're starting to break down the stigma of SUD or substance use disorder with those patients. We let them know that there's somebody here that's willing to help. And a lot of times, like I said, those cards are given and follow-up phone calls are made. And we are identifying ourselves as, safe places that at least are willing to help. And that's really not been the experience of a lot of these patients over the years. And that's why a lot of them, they're resistant to change if you ask them about it, because they know that they're going to, somebody's going to make a comment, or, they just been through so much with this before attitudes and beliefs have started to come full circle and people are understanding how huge of an issue this is. So you can, like I said, you can, number one, track your patient touches, your encounters, and then ideally, if you can track how many of those patients were actually linked to care and retained in care. That becomes a challenge when you're referring out, but still, any data is good data, especially when you're presenting to hospital administrators. So some of the pitfalls that you'll have with your program as it relates to peer recovery and warm handoffs is the lack of integration. Like I mentioned, will limit your patient encounters. So if they're only on call, or they're just sitting in the ED waiting for you to call them, there's some opportunity lost there. Any over dependence on physicians to navigate the outpatient world is a major pitfall. You need a peer recovery coach or a streamlined process. Another example that I didn't mention in here that is in the community, in a lot of the communities, especially around Southeast Michigan, is Families Against Narcotics. So we have some local organization or local EDs that are not big. They see 10,000 patients a year. They don't need an embedded peer recovery coach there, but they have the number for FAN and a system to work out to either call to have a peer recovery coach come to the ED, or just call and have them help set up outpatient for those patients that you're starting on BUP and sending home. So the doc has a process that they know that there's somebody involved downstream to help them connect, and that peer coach, even though they're not physically present, possibly can still perform the duties of the warm handoff, where they are getting the patient an appointment, a time, meeting with them potentially as well in the outpatient setting or in the community. And another problem is if you have an unreliable community partner, which you would only know if you've are able to, number one, track the data, or number two, that can be anecdotal from patient experience, or somebody went somewhere and they were told that they had an appointment, they didn't, and you're hearing about this and after the fact, that's somebody obviously that's can be a pitfall to a program, and that would be another example of the failure of the Swiss cheese model that Nick had mentioned in the beginning of the talk. So in final, I guess we can open up if there's any questions, but can't emphasize enough that addiction is a disease and should be treated as such by medical professionals. And really, the peer recovery coaches or your social worker or your nurse clinical coordinator and that warm handoff they provide to the appropriate setting are really crucial, and it really patient dependent as well. So need that extra TLC in order for that the Swiss cheese model of success to line up for the patient. A few references and our contact information for anybody that would be interested in following up after the fact. Nick and I, as well as 4 or 5 other docs that are all spread out across the state, are available to you guys just for us to chew on your ear, provide technical support or advice going forward.